When we decided to do another webinar, I was wondering what condition to look at, and I wasn't too sure about plantar fasciitis, to be honest, because obviously I did it a couple of years ago. Some of you may have watched it back in, I think it was November 2015. But as I say, well over 200 of you have signed up to this, so I guess a lot of you want a review and an update. So there's going to be a few repeats of slides, because obviously plantar fasciitis hasn't changed that much over the last couple of years, but there are also a lot of new slides in there, and there's some reference to new research as well that's come out, especially looking at sort of treatments and things. And then also I think it's always really good to have a recap anyway. So this is some of the topics that I'm going to look at covering. So first and foremost on the list, and very important, I've put anatomy. And I know I always bang on about this, but I think knowing your anatomy well is absolutely fundamental to everything we do, especially making a diagnosis, and that's for all conditions, not just looking at the plantar fascia. It's very easy to get lazy with this, and I'll put my hand up to this as well. But if you're not covering certain things regularly, I think it's very easy to forget. So it's all too easy to assume that heel pain is plantar fasciitis, when in fact it could be something else. But as I say, I'm not going to spend the whole time talking about anatomy. But it is very, very important. So some other things we're going to look at is pathology, etiology, differential diagnosis, and making a diagnosis. We'll look at the risk factors, and importantly, we'll look at different treatment options. And through all of this, we will look at the research which backs up what we're saying. So just a little note on plantar heel pain. Now, I read something a couple of weeks ago in the British Journal of Sports Medicine, and unfortunately I didn't make a note of the reference, so I can't even remember what year it was or whether it was recent or not. It was something that had just come up on one of these Facebook posts. But it basically queried the term plantar fasciitis, and it suggested that we're probably overusing this term or overdiagnosing it. And this is largely, I think, because everybody knows what it is. And when I say everyone, I mean your patients. So the article basically listed a few names here to describe pain underneath the heel, and these are terms I've had from doctors, from patients, and various people coming in. So plantar fasciitis, plantar fasciosis, plantar fasciopathy, policeman's heel, gonorrheal heel, heel Spurs syndrome, subcalcaneal pain, jogger's heel, and plantar heel pain. Now, I've never had anyone come in and say they've got gonorrheal heel, thank goodness, because I don't know what I would have done. But I think really what this list highlights is to think about what we're actually calling it and why, and whether we should be generically saying plantar heel pain until we've really gone through an assessment and said that it is specifically plantar fasciitis rather. But today, in particular, we are focusing on plantar fasciitis, not any of the other general terms of heel pain, although this will be discussed in the differential diagnosis. So just a bit of a recap here. Now, according to the literature, plantar fasciitis is the most common cause of heel pain, and most common cause that we're likely to see in our clinics. In actual fact, good evidence for the actual causes of plantar fasciitis is quite poor. But weight gain, occupational related activity, anatomical variations, poor biomechanics, overuse, good old inadequate footwear, all of these things are generally thought to be contributing factors. Plantar fasciitis is generally regarded as self-limiting, but sometimes it can take months or even years to resolve, and this can present quite a challenge for clinicians. Now, in 2003, Crawford quoted in a paper that 10% of the patient population, or the 10% of our population, is likely to suffer heel pain at some point in their lives. Now, it says heel pain, not plantar fasciitis, and the paper was also taken from America, so it can't necessarily be sort of transferred to a UK population. Now, I've read somewhere that in the UK it's quoted as 1 in 4 people will suffer heel pain, but I couldn't find a reference for that. But either way, I think we know heel pain is quite common. Now, the actual purpose of the plantar fascia is to provide support for the arch and to act as a shock absorber, and we will go into that in a little bit more detail as we go on. So this is a very simple sketch here of the basic anatomy, just to get us started. So if you can just sort of look closely there, you can see that the origin is in the medial calcaneal tubercle, and it inserts into the proximal phalanges and into all 5 digits. You can also see from this image that it's a stabilizer of the medial longitudinal arch. Right, now we get a bit more gory here, a bit more depth. So this sheet of fibrous ligament-like tissue is a potential energy store which releases energy on propulsion. So the plantar fascia, as you can sort of see quite clearly, it's been stripped back there. It's a thickened fibrous sheet of connective tissue that originates from the medial tubercle on the bottom of the calcaneus, and then it sort of fans out and attaches into the plantar plates of the metatarsal phalangeal joints to form the medial longitudinal arch of the foot. Now you can see from this picture that it's not the only structure going on here. I think sometimes when we look at simple pictures of plantar fascial problems, or like the one I just showed on the previous slide, you sort of see one structure. There's a lot of other stuff going on here, and there's a lot of other intrinsic muscles and other structures. And as I said, I'm not going to go off on a tangent for 30 minutes pulling apart the anatomy, but if you are interested in learning anatomy, do keep an eye out on our Facebook page and our emails, and look out for an anatomy course, hands-on functional anatomy course, which we will be running on the 6th of July in Norwich. Now, we've not advertised it yet, but it will be advertised within the next couple of weeks. So if you're not already on our mailing list, or if you're not on our Facebook page, sign up to it, because it's not all advertising stuff. There's lots of really good info that comes out on there as well. And that is all I'm going to go into on the anatomy. So this is really basic pathophysiology. It's usually quite a good way of explaining to your patients as well, but as I say, we'll go into it in more depth. So when we take a step or we walk, a heel makes contact with the ground first on the lateral border. Just as it starts to make contact, the tibia turns inwards, the foot pronates, and this puts a stretch on the plantar fascia, and the arch flattens. So the purpose of this is to allow the foot to accommodate for changes on the walking surface, and it's always, and to quote some old papers, it's an effective mobile adapter. Now, it's thought that the repetitive movement of walking or running can cause micro tears in the plantar fascia. Usually this tends to happen at the origin of the plantar fascia, at the medial tuberosity of the calcaneus, which is where a lot of patients present with the pain. But there are some studies that have looked at biopsy specimens of affected tissue, and what they found is that there's degenerative changes to the fascia, but it's not necessarily with inflammation. And this is an interesting point, and we'll come on to that in a few slides' time. So, mechanics. Hope everyone can hear me. I've got no way of telling on this if you can hear me or not. But since no one's emailed me, I'm guessing you can. Right, so before we go on to the treatments, I think it's all too easy just to say how to make a diagnosis and these are all the treatments. And of course, there's tons of treatments and we could discuss that for a long time. But I think it's fundamental to really understand the mechanics behind what the plantar fascia actually has to go through, because this is going to be paramount to your treatment and also your success. So I think it's a bit like working out what's wrong with your car before you decide what needs fixing and how. Although having said that, these days the mechanics just plug it into a computer. But as I say, if you go back a few years, you sort of know what I mean. Now, there's all sorts of different orthotic adaptations that you can try to treat problems with the plantar fascia, and lots of companies use this for marketing purposes. And if you look stuff up on internet sites, so things like medial heel posts, good old plantar fascial grooves, Versamet cutouts. But really, the same thing doesn't work for everyone, and you will get much better results if you take the time to identify what's actually happening in your individual patient. So let's have a little sort of closer look at the physics here. Now, I can't really talk about first ray function without mentioning Dannenberg. And I know sort of Dannenberg hasn't written anything for a while, and some people might think it's a little bit old hat, but I think understanding some of the stuff he wrote a few years ago is fundamental to understanding some of the newer stuff that came out. So it's worth looking at his papers if you're interested in this, and most of it centres around first MPJ function, which he says are essential for the foot's natural functioning gait. So basically, if you don't have enough range of motion functionally, or if you have sagittal insufficiency, and the whole foot doesn't really function as it should, and this affects the auto-supportive mechanisms. So these auto-supportive mechanisms, I've listed them there. These are the Windless Mechanism, close packing of the calcaneal cuboid, and the locked wedge effect. Although we don't really nowadays we don't really think of the foot as actually locking anymore, but I'll come on to that a little bit in a minute. So let's look at the Windless Mechanism. This is quite a nice picture because it shows what's going on in engineering terms too, so it can be a little bit easier to understand. So if you imagine the first MPJ is a bit like a pulley system, and the hallux is a lever, and the plantar fascia is a piece of cord, what you can see is that as you dorsiflex the hallux, it pulls on the plantar fascia and draws the heel and the first MPTJ closer together. And what the result of this is that it causes the arch to raise upwards. Now, a different picture here. So it's a bit like a winch mechanism. As you dorsiflex the hallux, it pulls the plantar ponderosus tight and raises the arch. But this isn't a new concept at all. So Hicks came up with the idea 60 odd years ago, but it has been adapted and developed by various researchers since then. In actual fact, at Biomechanics Summer School last year, Kevin Kirby and Luke Kelly and Ben O'Nig all talked about the windless mechanism. So they used that as a basis for some of the new thoughts that are coming through. So it's very, very important to understand this. Now, there's obviously a lot more to the foot than just bones and the plantar fascia, but it is a very good starting point to understand all the rest. So, once the windlass starts to take effect, as we go through gait, the heel is gradually unloaded and it raises from the ground, and the body weight is then compressed through the midfoot. So this puts what's called a compressive force through the midfoot, which stabilizes it and makes it strong enough to take our body weight. So eventually, as this raises up, the foot becomes stiffer. Now, it makes perfect mechanical sense, but if all of these things don't quite come together at the time that they should do, because the hallux hasn't dorsiflexed properly, then the mid-tarsal joint may become less stiff just as the heel comes off the ground, and you can get various different things like at late mid-stance. You get excessive pronation, you might get an adductor and abductory twist at the forefoot, you might get delayed heel off. Could also see more flexion in the knee and the hip. This is just to name but a few. But all of these things can cause symptoms, especially plantar fasciitis, because it's effectively being overstretched repetitively. So it's a bit like a car when the tracking's gone. In fact, I find this whole car thing really good, a good analogy to explain to patients, because they seem to get cars better than they get biomechanics. If you try and explain biomechanics in too much detail, I tend to find they glaze over a little bit. So there we go, you can see our body weight coming down there, ground reaction force coming up, and that effectively causes a compressive strain, compressive stress, which stiffens up the foot, ready for propulsion. Now, here's a new thing. At Biomechanics Summer School last year, Kevin Kirby talked a lot about the windless mechanism, and it did make a lot of us rethink things a little bit. So he talked about the LALSS, which stands for the Longitudinal Arch Load Sharing System. And what he pretty much said is that if one element in this system fails, then the whole system still works, but you're putting more strain on one of the structures. So the 4 layers that he talks about for the medial lateral arch was the plantar fascia, the plantar intrinsic muscles, post-tib muscle, flexor digitorum longus, flexor hallucis longus, peroneal longus, and also the plantar ligaments. Now, what he did emphasise was that the longitudinal arch is spring-like and that it doesn't lock. So we need to get away from the idea of locking. And the idea now is that it goes through various degrees of stiffness. Now, as I said, if one element of this LALSS system fails, then other elements will still be able to maintain the longitudinal arch integrity, but it will increase tension and loading forces on other structures. So if we're looking at things like plantar fasciitis, it could be that one element in this system has failed, which can cause the plantar fascia to undergo greater stress than the body's ability to repair. And I think this really highlights the importance of a good examination, or good biomechanics examination, because you might be able to highlight if something is failing here. So it might be another structure that you're addressing to strengthen, to then take the strain off the plantar fascia, if that kind of makes sense. Right, this is a slide I've used before. I think, again, it's important to put emphasis on it, really. So anything that's got isis at the end of it, basically that means that there's an inflammation going on. And anything that's got osis on the end of it means that it's a condition or a process. So basically it's a bit more general. Now, when we call something plantar fasciitis, what we're basically saying, or what we're assuming, is that the pain is caused by an inflammation of the plantar fascia, or more the fact that there is an inflammation going on within the condition. Now, according to this paper here, which was written in 2003, so not a new paper by any means, it suggests that some presentations of plantar fasciitis manifest as non-inflammatory degenerative changes. And what the paper said is that what we should be saying is that, or what we should be calling is plantar fasciosis. So unless we know there's an inflammation, we shouldn't just assume it and put an isis on the end. I suppose thinking back clinically, some patients I've seen respond really, really well to anti-inflammatories and ice, and some people just don't at all. And now I look back on that, I wonder if some of those patients, the ones that it did work really well for, did have an inflammation, and the ones it didn't work for didn't. But obviously at the time I had no way of knowing that. So when we see these sort of generic how to treat plantar fasciitis, ice the area and take anti-inflammatories, I think it can work well if it's inflamed, but if it isn't inflamed, then that's never going to work. So do remember that, because evidence does suggest that there isn't always an inflammation going on. Right, so let's have a little look at the causes of this condition. And according to Riddle, 85% of cases, well, we're not entirely sure, but we do have to make sort of assumptions for this. So in athletes or active patients in particular, plantar fasciitis appears to be associated with things like training errors, sudden increase in activity, maybe someone that's decided to run a marathon, overuse, running on hard surfaces, or again, maybe somebody's decided to take up road running. I'm not sure how many of you have had stuff like that coming after Christmas with New Year's resolutions. And then we've also got good old inadequate footwear. So basically, the patients haven't got the right tools for the job. Now, all of these things can cause micro-trauma to the plantar fascia, and the important thing to remember is if you're getting these micro-traumas, if it exceeds the body's ability to repair, then you will get problems. Now, it's not just our weekend warriors. In the elderly, things like poor intrinsic muscle strength or poor shock attenuation can be predisposing factors, along with things like pes planus, or simply the fact that the healing capacity of the body isn't what it used to be when these patients were younger or healthier, or they didn't have any other sort of conditions or problems going on. Now, there's plenty of risk factors for plantar fasciitis and plenty of studies to back them up. Another study here by Riddle in 2003 suggests that individuals with a body mass index of more than 30 are more at risk of plantar fasciitis, or significantly more at risk than those with a BMI of 25 or less. They also found that the risk of plantar fasciitis increased as the range of ankle joint dorsiflexion decreased. So patients with 10 degrees or less have more chance of getting plantar fasciitis. Now, if you look at this paper, they'd actually measured it with the patient lying prone, or the patient non-weight bearing, and they measured it with a goniometer while passively dorsiflexing the ankle joint. Now, that kind of comes with its own issues regarding repeatability, and we could argue that, but needless to say, there was a correlation between a limit in ankle joint range of motion and the increase of plantar fasciitis. So there obviously is a link there, even if we can't explain it properly. Got a few more bits to say there. Lots of papers suggest that individuals with pes planus or excessive pronation are thought to be at greater risk of plantar fasciitis. And it's not just your flat-footed ones, also your pes cavus tend to be more prone to plantar fasciitis because it's thought that they're unable to effectively dissipate tensile forces during weight-bearing activities. And then you've got other sort of anatomical risk factors have been suggested in various different papers, with things like limb length discrepancy, excessive lateral tibial torsion, excessive femoral anteversion, as I say, just to name but a few there, but they're quite old papers. So people with occupations that require prolonged weight bearing have always been considered to be at risk of plantar fasciitis. So maybe people that work in factories or wear safety boots, basically because of the repetitive tensile load that's placed on the plantar fascia. And if it's hard, unforgiving surfaces, then there's obviously not a lot of give or adaptability there. I'm just going to have a mouthful of water, if you'll excuse me. Now here's one for you, always worth mentioning, heel spurs. So has anyone ever had those patients that just get it stuck in their head that they've got a heel spur because maybe they've had an x-ray or something, and it's the heel spur that's digging in and that's causing the problem? See, this is where I think x-rays can be a bit of a pain, because once they see that, it's not everyone, but I've certainly had a few patients that I just cannot get that concept out of their head, because they've seen a spur, they think it shouldn't be there, and until in their mind they've had that spur released or taken away or surgically removed, they think the pain's not going to go away, and that can be quite a tricky one to deal with. So heel spurs have commonly been implicated as a risk factor with plantar fasciitis. But according to one paper, half of patients diagnosed with plantar fasciitis actually have heel spurs. But it's not clear how much influence heel spurs actually have on the condition. Another study there shows that only 5.2% of patients with heel spurs are actually symptomatic, which actually means probably a lot of us are walking around with heel spurs in the general population, and it's just an anatomical variance, and we're not actually getting any problems from it. But as I say, it's difficult to explain to patients, especially once they've got that idea in their head. And you can see the little picture I put on there. They just get all these ideas that there's something digging in, or there's a nail digging in, or a claw-like thing in their foot. So no advice on getting around that one, other than if you do have an x-ray with a heel spur on, maybe don't show them. Right, another risk factor to bear in mind, especially if you work with older patients or if you work in at-risk foot clinics, and that's diabetes. So it's not all people that have suddenly taken up marathon running that go to see sports specialists. Plantar fasciitis crops up in all areas of the population, and also diabetic clinics too. And basically this is really because patients with diabetes may suffer with things like peripheral neuropathy, and this can lead to muscle atrophy. They may also get changes in anatomical structure of their feet, like claw toes, high arches, prominent met heads, not to mention alterations in gait, and all those things can basically have an effect where it puts more stress on the plantar fascia. So what does our typical patient present with? So classic presentation of heel pain is pain on the sole of the foot or at the back of the heel. So they usually say that the pain is worse with the first few steps taken in the morning or after they've been sitting for a while. And in some cases the pain can be so bad that your patient may limp to keep the effective heel off the ground. Pain usually gets better with gradual activity, but it can become worse with things like prolonged weight-bearing activity. So while patients may not know what brought their symptoms on, it can usually be correlated with an increase in the amount or intensity of a physical activity, or being overweight or gaining weight. And quite often you can see it with pregnant women because they've gained a lot of weight in a short space of time, obviously because they're carrying a baby. So while they might say, oh, it just came on gradually, I don't know why it came on, if you're asking specific questions about their lifestyle and things, you can normally pinpoint something which probably just about predisposed this happening. So again, highlights the importance of asking lots of questions and taking a really good history and examination. So the diagnosis of this condition is, well, like I just said, made largely on the basis of a good thorough history and physical examination. So pain first thing in the morning is typical of plantar fasciitis, and it tends to distinguish it from other causes of heel pain. So it tends to be unilateral, but one paper quoted that 30% of cases have a bilateral presentation, although I have noticed that different papers will quote different percentages on this, but generally it's unilateral, or it certainly starts as unilateral. Your physical examination should include palpating the anterior medial aspect of the calcaneus, and you're looking for signs of pain. And pain may also be exacerbated by passive dorsiflexion of the hallux, or getting your patient to stand on the tips of their toes. And this is because you're actively stretching the plantar fascia. We mentioned earlier tight Achilles, so almost 80% of patients have a tightness in that area. MRIs and X-rays only really need them if you're going to try and rule out other conditions. But so you certainly wouldn't need that for everyone. I watched a presentation once where it was suggested that you get your patient to walk up and down, and if it hurts as the patient puts their heel on the ground, this suggests that the pain is closer to the insertion on the calcaneus, or the degeneration and the problem is closer to the insertion point. And if it hurts more as they go to toe off, that tends to be more because there's pain and problems along the course of the plantar fascia because you're stretching the whole thing. Now when I heard that I thought, yep, that sounds nice and simple, but I've tried that on loads of patients and generally they just tend to walk up and down and just say it hurts, so it's quite difficult to get them to pinpoint that down sometimes. Now, the signs and symptoms I've talked about are fairly well known, but there are sometimes red flags. They don't come up very often, but I think it is really important that you know this, because it might just help identify the causes. Now, I've not put all of them down here, I've just listed out a few. So things on immediate weight bearing, which becomes worse. If you notice things like bowed tibia, if you get headaches, deep bone pain, burning pain, diffuse nerve pain, numbness, nocturnal pain, pain with resisted motions, swelling, redness, adolescent boys I've put in there. So if any of these things sort of stick out and something doesn't quite seem right, then we sort of need to be thinking, not necessarily worst case scenarios, but we need to be thinking about maybe onward referral or looking at something else, which then brings me on to my differential diagnosis. Now, this is really where your anatomy comes into play, and also your red flag knowledge. And this, you shouldn't really be thinking this just for plantar fasciitis. You should be doing this really with everything with diagnosis. And I think one of the best ways to do this with any differential diagnosis is to work through the layers and think about what's there. So start with the skin, then work through to the soft tissue, then work through to the muscles, nerves and bone, and then that way it works through a process of elimination. Now, I've put a few suggestions here, and that might give you some clues depending on what they come in with. So maybe something like, I don't know, a sudden acute knife-like pain, that could suggest something like a plantar fascial rupture. History of acute impact injury may suggest bruising of the heel or a fractured calx, so if they've jumped off a ladder or jumped off a roof or something. Swelling and redness at the back of the heel could be a bursitis. Pain with resisted motion tends to suggest a tendinopathy, so maybe the flexor hallucis tendon. Tarsal tunnel syndrome, I've not seen too many of these, but that's likely to present with something that comes across as like a diffuse nerve pain over the plantar surface of the foot. Trapped post-tib nerve may cause nerve pain just on the medial heel, and if the adductor digiti quinati nerve is affected, the patient may feel a burning pain over the whole heel. So really, when you get your patients to describe, try and find out from them what sort of pain it is, because that will give you an idea of whether it's, say, tendon, nerve, bone, what kind of structure might be involved. Pain that worsens with prolonged weight bearing could suggest a fracture, and if you're dealing with adolescent boys, which is one of the points I put on the previous slide, then don't forget Sever's disease, because that is quite common, especially in boys aged, I can't remember what the research says, but I'm just talking from clinical practice now, between about 8 and anything up to about 16. So yeah, don't forget Sever's disease and all of that. Now, bowed tibias, kyphosis, headaches, deep bone pain, nocturnal pain, all of these can be signs and symptoms of something more serious like bone tumours or Paget's disease, and this would definitely need instant onward referral. But these are very few and far between. I mean, I've been qualified since 2003. I've worked in private practice, NHS, where I've just been doing solely biomechanics, and I've only known of one patient who had a bone tumour, and actually that wasn't my patient. It was somebody else's, and that was knee pain. So only one, but the symptoms just didn't add up, and it just all didn't make sense. And they were, I mean, that was sort of an emergency surgery case. But so yeah, only one in all my years of practice, and it wasn't even my patient, but they do appear. So I think if there is a red flag there, you know, don't hesitate to refer on or get a second opinion there, because they are about. Right, okay, so on to treatment. And most of these I think we're probably fairly familiar with. Now, there is an argument that plantar fasciitis is self-limiting, but it can also take quite a long time, even months or even years, for this to resolve, if at all, and patients don't always want to wait that long, or it might interfere with their lifestyle. So here I've got orthoses, stretching, what else have we got? Cold bottle rolling, cross-frictional massage, lifestyle changes, physio, strength training, ESWT, which I'll come on to, steroid injections, and sort of worst case scenario surgery. Now, I have read papers in the past that have talked about nutrition, and I haven't listed them here, and I guess this is really looking at the bigger picture with regard to just general good nutrition and getting good tissue repair. Might be worth considering if you've got elderly or ill patients with plantar fasciitis, just as part of your whole kind of holistic treatment regime. As I said before, icing and inflammatories, they work really well on some patients and not others, and we talked about this with our isis or osis slide. Lifestyle changes and losing weight are always good suggestions, I think, with any condition. And also it puts more onus back on the patient to be sort of doing something for themselves as well. Trouble with this is that you are relying largely on the patient to make the change, and that can be a challenge in itself. If you have easy access to a physio, then definitely think about using those as well. I think you get better results and compliance if you have a multidisciplinary approach. I don't know whether that's because several different clinicians are telling them the same thing, or whether they feel more looked after and nothing's being left out because there's different clinicians. But certainly having an experience of working in a multidisciplinary private practice, I know we always got really good results when we all treated the same patient for the same thing. If all else fails, you've got surgery, but I do think that's a bit extreme. But I mean, there is a place for surgery, but again, few and far between are the cases. Right, a little funny picture there for you just to break things up. Now, the most fundamental thing, in my opinion, when it comes to treatment is to truly understand exactly what it is that you're treating. So very often the patient will come in and they'll tell you they've got plantar fasciitis because they've looked it up on the internet. But what you've got to consider is, do they actually know what plantar fasciitis is? Just because they've looked up heel pain and got plantar fasciitis, that doesn't mean it's a diagnosis. And also, I remember getting a GP referral years ago who told me the patient had plantar fasciitis, and as I read through the letter, he described that it was on the dorsum of the patient's foot. So yeah, top tip there, I think, is really know what you're treating. Don't, because somebody else has referred it in as plantar fasciitis, you make your own judgment on that through your own examination, and don't skimp on the examination either, because you don't know if you've missed something. So now, can't talk about this without talking about orthoses. Now, there's lots of papers supporting the use of functional orthoses for the treatment of plantar fasciitis. And to be honest, I could write a whole presentation on this, just this on its own, especially if I pull some of the papers apart. Trouble with research is, for one paper that says one thing, you can always find another research paper that says something else, and you can always choose to sit on the fence. So some papers look at different types of orthoses, or they make different corrections or materials. A lot of papers will use different outcome measures. So when you're trying to compare research, it is difficult, and you can get really sort of stuck into this. But I think we all know, I mean, if orthoses didn't help improve symptoms, I'd certainly be out of a job for once. So with most of you, so we know they work, but it's very difficult to pinpoint correctly with the research how they work. Now, I've picked a couple of examples of papers, although I probably ought to get some more recent ones, to be honest. But this study here at the top, quite a good paper, because it looked at 236 participants, and they concluded that prefabricated orthoses were superior to both custom-made orthoses and stretching alone. But what they did also mention in the discussion was that custom-made orthoses and stretching alone also showed really good results. So whether using custom or prefab, both worked really well. There's another study here by Lynch, which was a randomised clinical study of 103 patients, and they looked at 3 different treatment categories. So one of them was anti-inflammatories on its own, the other one was accommodative insoles, and the final category they termed mechanical, and the mechanical category consisted of low dye taping for 1 month, followed by rigid custom orthoses for 2 months. Now, after 3 months of treatment, they found that 70% of participants in the mechanical treatment group, so the ones with the taping and the custom orthoses, rated their outcomes as excellent or fair, and compared to the anti-inflammatory and accommodative treatment groups. So these are just 2 papers, but like I said, there's lots and lots more that you could pull out. Oh, we've got one final paper on there that I've put. So this is a little bit more recent. But this is an interesting point here. While it shows that correcting the foot position helps reduce symptoms, what they make quite a point of in the discussion is outcome measures. So what their findings suggest is that we should have more objective measures for outcomes, such as spontaneous physical activity improvement. So they may be more sensitive, so things like this might be more sensitive or specific for detecting improvements in weight-bearing function, rather than just saying, oh, does it hurt? Yes, it does. No, it doesn't. And I think this is something really important to bear in mind when you're measuring improvement. It's also worth bearing in mind when you're looking at research as well. So I think the VAS analog score is quite commonly used for those of you that do use outcome measures. but sort of function, movement, lifestyle, there's lots of other things that should be considered when we're looking at, if something's improving or not. Right, stretching. Now, stretching is an excellent tried and tested treatment. Again, it's all over the internet. I'm sure your patients, if they've looked it up, would have read this. Again, there's tons of papers that advocate it, but I think this is largely because tight calves are common with a lot of patients with this condition. Now, I'll always tend to prescribe calf stretches for all sorts of conditions, and also part of your patient getting used to wearing orthoses. But one interesting paper here is by Piper. They mentioned that myofascial release to the gastroc and plantar fascia is quite effective for the use of plantar fasciitis, although I've never tried that. I'm not sure what the current thinking is with calf stretches. I think I always used to sort of think stretch for 20 to 30 seconds, repeat 3 times, do it 3 times a day. Now, the problem I always found with this is that patients just aren't good at doing their exercises. And I still found, whether it's the best to do research-wise, but I still found the best way for doing it is just to get a book for your patients to stand on or a piece of wood, drop their heels off the edge, and to incorporate it into something that they always do as part of their daily routine for a couple of minutes. So be it washing up, doing their hair, I don't know, cleaning their teeth, shaving. So anything that they can incorporate into their daily lifestyle routine, I found patients were much more compliant doing that, especially if they've got busy work schedules, because they're going to be standing there brushing their teeth anyway, or they're going to be standing there peeling the veg or washing up anyway, so they might as well be stretching at the same time. Whereas when you give them homework as such, where they have to go away and do these proper stretches 3 times a day for sort of X amount of seconds and minutes at a time, if they're busy, they'll forget or they won't have the time to do it, and they're brilliant at making up excuses as to why they can't as well. So try and include it into something that they do as part of their everyday routine anyway. That I find tends to work better. Cortisone injections, now they've got their place. The research shows that they work compared to placebos, but they are short term and they do come with risks. Usually just small ones, although you have got a big risk of a ruptured plantar fascia. Small risk, but if it does happen, it's obviously not a small problem. I've referred patients for cortisone injections before, but usually it'll be in those patients that have got a chronic pain, nothing else works. And I think for me, it's just as if it breaks the pain cycle for long enough for them to be getting on with stretches or orthoses or whatever else you've prescribed. Having said that, I haven't referred anyone for cortisone injection for a long time, so in my opinion it just breaks the pain cycle, but there probably is a lot more recent research into how technically and how in depth it actually probably does work. So this is a bit of one that's attracted attention in recent years, ESWT, so extracorporeal shockwave therapy. As I say, it's received more attention in recent years. It's basically low energy sound waves. They work by increasing blood flow to the injured area, and it's mainly used for chronic plantar fasciitis. And there is some strong evidence for reliable outcomes. Now, a recent paper which I've mentioned here found it to be more effective for treating plantar fasciitis in middle-aged patients, and they also found that ESWT was effective in patients not only playing recreational sport, but also just activities of general daily living. Another point in that paper was they found it was more effective in patients with pain in the plantar fascia emphasis rather than patients that had the pain along the entire plantar fascia. If you're going to ask questions about this at the end, I've never used this, so I'm definitely no expert on advice with it, and as I say, it's all I've got is the information I've had from talking to colleagues and also looking it up in the research. I've not had any clinical experience using this. Now, as with most research, there's always a flip side, and this was quite a substantial meta-analysis research paper, which showed that focused shockwave therapy appeared to be associated with higher success rates and greater pain reduction compared with just a sham therapy for chronic plantar fasciitis patients. But what they said when they looked at all the papers was that due to limitations with included studies, they needed more larger sample sized, high quality clinical trials and systemic reviews to demonstrate quite how effective general ESWT is. And included in that was also FSW, which is focused shockwave therapy, and RSW, which is radial shockwave therapy. And they also mentioned in there to determine whether radial shockwave therapy is an ideal alternative or therapeutic alternative for conservative treatment or surgery. So it looks like there's quite a lot of ongoing research, or there will be some ongoing research looking at that. So now this is definitely a paper worth taking note of, the one at the bottom there by I was going to say Radcliffe, not Radcliffe. Yeah, the paper at the bottom, 2015. My screen is smaller than yours, so I can't actually read the small writing that I put on. References are all at the back as well, by the way. Now, as I said, take note of this paper because a lot of recent research has focused on high-load strength training for the management of tendinosis. Now, Peter Malliaras, or Dr. Peter Malliaras, who's a Australian physiotherapist, is quite a pioneer in this area. So if you're treating a lot of tendon injuries, then it's definitely worth reading up on some of his papers. Now, comparisons have been made regarding the structure of tendons and the structure of the plantar fascia. But this paper here that I'm mentioning by Radcliffe, I can read it now, tests the fact that you can use a tendinosis treatment approach on the plantar fascia. So what works on the Achilles tendon will also work on the plantar fascia. So really this is an excellent piece of fairly new research which explores how the plantar fascia can be managed with high load strength training. And this is something which you could quite easily do in your clinics with regard to prescribing exercises, rather than just giving them calf stretches, ice bottle roll, and giving them orthoses. Now I'm going to read through it because I've got some notes on this. So this slide just shows you a basic 1, 2, 3, 4 and how to do the exercises, but I'm going to skip on to the pictures and then I'm just going to sort of basically read through what you need to do. Now it's called unilateral heel raises with towel inserted under the toes to further activate the windless mechanism. Now, first of all, the towel in this image, it needs to be individualized to ensure that the patient's toes are maximally dorsiflexed at the top of the heel raise. So depending on the size of the patient and their toes and everything else, it's not just you roll the towel in half and you use the same on everyone. You've got to individualize this. And then the calf raises need to be performed slowly to decrease the risk of symptoms flaring up. So always start slowly, don't sort of jump into it and cause yourself more problems. Now each heel raise should consist of a 3-second concentric phase, so that's the bit where they're going up, a 3-second eccentric phase, which is the bit coming down, and then in the middle of that what you want is a 2-second isometric phase, and that's just a pause at the top of the exercise. So it's really important to make sure these patients do it slowly and gradually, and that you really kind of coach them and teach them how to do it. Otherwise they'll go away and start bouncing up and down on a piece of wood with a towel, which won't do them any good or sort of anything else. Now, high load strength training does need to be progressed gradually. So what you want to do is start with the maximum load that your patient can tolerate while performing the lifts 12 times and repeating 3 sets. So again, this is very individualized. It's also really important that your patient maintains a proper form while they're doing this. So after 2 weeks, what this paper suggests is that the load can be increased with the use of backpacks and books. And then the number of repetitions should be decreased to 10, but the number of sets increased to 4. And then after 4 weeks, you increase the load again, but decrease the repetition to 8 and increase the sets to 5. So it sounds simple enough, but it is really important to tailor this to your specific patient. So if you've got an older, less mobile patient, they'll be a lot less likely to perform high loads compared to a 23-year-old athlete. So there's absolutely no size fits all. It's very individualized. Finally, the patients should perform the exercises every second day for 3 months with careful monitoring. So I'll just go back to that again. So I've obviously gone into more depth explaining there than I've written here. And if anyone's interested in this, just drop us an email and I'll send you an overview of the notes I wrote for this research paper. But alternatively, just go and look up Radcliffe, the paper in 2015, was 2015, wasn't it? Yep, 2015. High strength training for plantar fasciitis, and then you can read the whole thing through. But yeah, it's definitely I think if you're treating a lot of patients with plantar fasciitis, this is a really good one that you could certainly try with certain patients. And if you think you're doing this and you're doing stretches and you're doing custom orthoses or prefab orthoses, whatever, then you're using lots of different elements as part of your treatment. So you're not just holding the foot in the right position and loosening up the calves with stretches, you're also looking at strengthening in with that as well. See a picture. Now, while we're on the topic of smaller muscles in the foot, I can't really go on without mentioning something which I took from a lecture from Benno Nigg at the Biomechanics Summer School last year. Now, I'm going to put this really, really briefly, and obviously Professor Nigg puts this in much more evidence-based context than I am. But what he essentially said was that smaller muscles react faster than bigger ones. Strong small muscles increase stability and decrease pain and injury likelihood, and that's exactly what he said. So it's a pretty bold statement, but he said it, and I guess he knows. But for me, it really highlighted the importance of strong intrinsic muscle strength. And I think I probably knew that anyway, but certainly going back, I don't know, years ago, I think I focused so much on getting the foot in this correct alignment that I probably didn't concentrate enough on keeping your smaller muscles strong. And you might wonder why I've put a picture there of the Burj Khalifa. An analogy that Benno Nigg used was that if you were going to build a really, really, really tall skyscraper, where would you put, or where would you want your strongest structures to be? And then he had a picture at the top, in the middle, and at the bottom. And if you think about it, you'd want it at the bottom or want it at the base. And really, that was just to emphasise the fact that the muscles in your foot and your ankle need to be really strong to support everything higher up. So I just put that picture in there, as I say, because it sort of reminded me of that a little bit. So, and if we think back to the slides I showed earlier, Kevin Kirby's work with the low longitudinal arch sharing system, and he said if one of those structures fails or if there's a weakness, it puts pressure on other structures. If you think about it generally, if you've got strong intrinsic foot muscles, you're much less likely to have problems in other areas. So, and this is something you could use on elderly patients as well, even if it's just picking up pencils with their toes or scrunching up towels, or there's all sorts of different ones, and you could look them up. But strong intrinsic muscle strength is really, really an important part of all of this. And just remember, the anatomy of the foot is not just the plantar fascia that's in there. And there's lots of other things that play a crucial part in maintaining foot structure and basically having a healthy foot. Now, this is just a point in case here. This is not evidence-based at all. It's just based on what I've found over the years. Now, I've treated probably thousands of patients with plantar heel pain, and in those I can only think of 4 cases where the pain wasn't related to anything physiological or mechanical, and they were in fact all related to abuse cases. So it's really, really rare, and I've got no sort of tips for dealing with that, but as I say, you do once in a blue moon get the odd case where someone's coming in with recurrent heel pain and it just makes no sense whatsoever. You've ruled everything out, they haven't got bone cancer or anything else, and then eventually it crops up that there's a lot of other things going on in their lives, and to them it's probably manifesting as a very real pain, but there's all sorts of sort of psychological issues around that as well. So it's just a point to just remember that this does happen. Now, outcome measures, we touched on this a little bit earlier, but I think it's always important. It's not as black and white as you come in with pain. Now I've done all my tricks and treatment and you don't have pain. And if you've still got pain, it hasn't worked. I think it's just not that black and white. It may be that the pain hasn't decreased, but your patient can do a lot more now. So in older patients, maybe the pain's kind of still there, but instead of just walking to the front door, they can now walk all the way to the shop and back. I suppose another example would be a runner who gets symptoms after 5 miles. So you could just say only run 4 miles. But there's lots of treatment things you could do, and you could probably get them reaching, I don't know, the 10 mile or even the 26 mile mark if they were looking at running marathons. So we could be looking at ability. Also need to think about patient expectations. So what are they expecting when they come in? Are they sort of coming in, wheeling in a wheelchair and expecting you to make them walk again? A lot of this comes with the conversation you'll have and the history you take and the examination that you do. BAS analog score, it's quite a good easy one, but I would probably do it at the start, so you can mark where their pain is on a scale of 1 to 10, or with kids you can have smiley faces, and then do it at the end. So maybe they've started, their pain was 9, and when you finish their pain was 5. But as I say, also think about activity levels on there. So to think about it in a much bigger picture, not just you have pain, you don't have pain, and it may well be that you've got improvements, but you've not noticed them in other areas. And we're sort of just about getting ready to bring it to a conclusion now. So I think to sum it all up, the most important thing is not just making the right diagnosis, but working out exactly what's causing the problem in your patient, and remembering that every patient is different. Now I've talked far more about the causes and diagnosis of plantar fasciitis than I have about the treatment, and that's because you really have to keep it real. So there's really good evidence for some of the treatment, but it's no good giving things like intensive exercises and rigid functional foot orthoses if you've got a patient that's 85 years old and they've got diabetes and arthritis. So it has to be always specific to your patient. And also just don't skip the obvious. I think sometimes we look too hard for complicated reasons, but if they've come in and they've got a BMI of over 30, then you're not going to have great results doing anything unless the weight loss is addressed too. And so outcome measures on there, pretty much just gone over that. So I mean, really that's managing patient expectations. And as I say, perhaps your problem won't resolve completely, but their ability to do things may be a lot better. So yeah, that's it, I think. Well, good luck. Thanks for listening. I've still got no idea from this system whether I've got questions or not, or how many people are logged on. So I think there's also a 30-second delay on this. So while you're catching up, I'm going to try and work out where the questions are. And then I'll stay online and read some out and try and answer them for you. Oh, there's your references there as well. You can watch this webinar back afterwards. It will be on YouTube and you'll get an email sent from LBG Medical with a link to it. So what you can do is that you can watch this through, and then if you pause the video when you get to this slide, then you can sort of zoom in and have a look at the references. I will say now though, I think if my MSc tutor saw the way I'd written these references, she'd have a heart attack. So they're not perfectly put, but as I say, if you look them up, it's got all the details there. But I don't know if any of you guys remember from uni days what a pain it is when you leave the references to the last minute and they've all got to be properly sort of written out with the right commas and everything, but I haven't done that, I'm afraid. Right, where are these questions? Right, someone's just said, can you just recap on the reps, etc. for the high load strength training, please? How do I get back to this? So I'm going to go back to that. Okay, I haven't actually put the reps on there, so what I'll do is I'll read them out again. But as I say, you will get a copy, you will get a link to watch this presentation again, so you can kind of stop and pause to listen to it. So what they suggest is you start with a maximum load your patient can tolerate while performing the lifts 12 times, repeating 3 sets. After 2 weeks, the load can be increased with the use of a backpack and books or weights. Then the number of repetitions should be decreased to 10, but the number of sets increased to 4. Then after 4 weeks, increase the load again, and then decrease the repetition to 8, but increase the sets to 5. And then you want to be doing this over 3 months, but with careful monitoring. Oh, we've got loads of questions on here now. Someone's put, can we download your slides? Yeah, like I said, you can watch them later, and you can press pause and stop and play and rewind and everything. So, but if there's any specific information that you want that isn't covered on there, then just drop us an email and then I'll get back in touch with you. Someone's put, what's your opinion regarding K-taping and low-dye taping? It's one of those things, I kind of get it. I have done it about 3 times, but and that was only because the patients were like massively compliant, and that was in private practice. But I don't know, I find patients don't apply it as well. It gets a bit messy and a bit sticky. I mean, it's great for things. I mean, I used to do a lot of martial arts, so it's great with stuff like that. You can just do it at the mat side and tape it up, because obviously you can't wear orthoses when you're training on a mat or you're doing any kind of exercise barefoot. So that's got its place. But I've got to be honest, I'm more in favour of I suppose my gold standard thing I like doing is stretching, orthoses and muscle strengthening. But that's not to say low-dye taping and K-taping hasn't got its place, and when it does work and when you've done it properly, it can work really, really well. Someone's put eccentric stretching for Achilles, suggest trainers, stretches shown barefoot, wonder why. I don't know, actually, to be honest. I mean, my question there would be, it depends on the trainer. I mean, there's so many different types of trainer that you can use, isn't there? And some are minimalist and some are maximalist and some are heavy and some are light and some have got 5 toes and some have got no toes. And so I don't know, I'd have to look more into that one. Lateral hand plantar heel pain. Don't see much of that, do you? I'd be thinking nerve entrapment, so I'd be asking more questions about what the pain feels like. I'd certainly be asking a lot of questions about where it came on, why it came on. I mean, sometimes you can get like pain on the lateral because of the fat pad, and something that can work really well with that actually is just making sure you've got a good solid heel cup, because what it does is it kind of, in very basic layman's terms, it kind of squashes the heel pad back in, so it's sort of in the position that it should be in. If a patient has a cavoid foot, would you use orthoses? Yes, I would. But again, it depends what you're trying to address. So there's 2 different thoughts with cavoid foot types. One is that you use a softer material, so you're addressing the shock attenuation, because obviously cavoid feet tend to be stiffer and more rigid. The other thought is that if you've got cavoid feet, the problem is the pressure areas, so that the highest pressure areas tend to be under the first, under the fifth, and under the heel. If you have a more rigid device which covers, so it goes right up into the arch and covers the whole plantar aspect of the foot, then what you're doing is spreading the load over a wider area, so you decrease the pressure on those main points. But maybe if it's specifically plantar fasciitis, I'd be looking at just a more shock attenuating material, so maybe a lot of EVA and Poron to take up the shock. But yeah, I definitely wouldn't rule out orthoses for a cavoid foot. They're more tricky to treat, but only because you've got to work out exactly what you're trying to do with them. Missed them. Someone's put, I've got lots of reading to do. Yep, you can't just take my webinar. That's why I put references on, so that you can go and read stuff up. So. Right, someone said I may have missed it because they've been out and about for the presentation, but can you talk through the specification of your preferred foot orthoses utilised to address plantar fasciitis? That depends entirely on what I think is causing the problem. Now, if they've got a functional hallux limiter, so they've got plenty of range of motion when you're looking at the non-weight bearing, but when they're weight bearing, you can hardly budge the hallux, then I definitely want something on there like a first met cutout or a reverse Morton's, or I mean, that depends on the footwear that they're wearing as well, but definitely something which addresses making the first ray function more. Also, I usually tend to put a medial heel paste on there as well, because that kind of takes the slack off the plantar fascia. So they're 2 things that I probably do a lot. I mean, sometimes I'll put things like heel pads or put a softness in the heel, or you can do heel punches on functional orthoses, where it takes a bit out of the shell, and so they've got a nice sort of squidgy bit to sit on. I do prefer higher heel cups because I think that holds the fat pad well, so you're addressing shock attenuation there as well. So, I mean, if you look at some of the research and the papers on it, they talk about heel pain, or I say heel pain rather than plantar fasciitis. look at two mechanical things that cause it. One is the pulling or the tensile force on the plantar fascia, and the other is the compressive force on the insertion point or the calcaneus. So that's as your heel hits the ground, so you sort of ground reaction force coming up. So to address the compressive force on the calcaneus, then you want to be looking at a good shock attenuating shoe or good shock attenuation in your orthotic. But also if you've got high heel cups as well, as I say, it kind of molds and kind of holds your fat pad in a better position, so that's acting as a better natural shock absorber than if you've got no heel cup there at all. But again, you've got to think about footwear accommodation. If you've got a female coming in and they've not got much in the way of footwear, if you're putting high heel cups on there, it's not going to fit, and that's going to cause you problems as well. So plantar fascial grooves is another thing you can ask for. You do need to you need to mark exactly where the plantar fascia is on your cast when you send it into the lab. That works really well if you've got patients where you can see their plantar fascia really clearly on the surface anatomy, and it almost looks like a bowstring, because if it's that tight that you can see visibly, if you put an orthosis under there, or even the padding in a shoe is going to kind of it's going to I don't know, trap it. So if you've got a plantar fascial groove, it allows that to sort of move and run freely through it. Although, as I say, I don't sort of use plantar fascial grooves that commonly, but yeah, they're the main things that I suppose I use most commonly. But you've got to think that it isn't just right, I'm going to use the first mech cutout, medial heel post, and a plantar fascial groove on every single plantar fasciitis patient, because it does depend exactly what you're addressing with that patient. Is there any evidence for patients with rheumatoid arthritis that makes a patient more prone to plantar fasciitis or OSIS? Yes, there is, but off the top of my head, I couldn't quote it for you. Jim Woodburn has done a lot of research looking at rheumatoid patients, and he highly advocates that if you catch a rheumatoid patient early on, you need to treat them with a custom rigid foot orthoses to stop the foot basically changing shape. And again, in basic terms, with rheumatoid arthritis, it is progressive. So you start with a nice, perfect looking foot, and then over time, you end up with dislocations in the joints, and the whole foot shape changes, and it completely collapses, and then it pretty much goes past the point of no return. So as that happens, obviously, all the structures are going to get stretched with that as well, and the plantar fascia could just as easily, or is quite commonly, one of them as well. So the importance with that is getting in there early with it and making an orthosis which holds the foot in the best position and basically takes the pressure off of all those structures. But yeah, have a look up Jim Woodburn and some of the research he's been doing up at Glasgow, because that will be addressing that. Yeah, most consultants now say injections are a big no for the plantar fascia. Do I think it's still a place? I've got to be honest, when I referred them on, I'm going back to 2004, 2005, so well over 10 years ago, and that was part of a multidisciplinary triage clinic that I used to do, and often they say they were referred in there just to break the pain cycle, but it's just something, I don't know, I've not really heard about in recent years, although I was talking to someone from an NHS trust a couple of months ago, and they said it did have its place, but it's done a lot less commonly than ever it used to be. And I think that's really because you don't want patients having repetitive cortisone injections, because then it sort of weakens things, so you've got more likely to have a rupture. So I think it's always best if you can use conservative treatment without invasive stuff going on. That's always the best way. But yeah, you are right, a lot of consultants now will say no. Oh, and thanks to everyone at the beginning that said they could hear me. Right, okay. Can you explain the MOSI specification, how it can benefit the patient with plantar fascial problems? So the idea of the MOSI, it stands for medial oblique subtalar inclination or shell inclination, I've forgotten which. But basically, this was devised by Paul Harradine and Lawrence Bevan a few years ago, and they wrote quite a good paper on this. Can't remember when, late 2000 and 2009, 2010, I can't remember. Anyway, look it up. And what they said was at the moment for patients, specifically if they've got a medially deviated subtalar joint axis, at the moment we tend to use the medial heel skive or the Kirby skive. And what they argued was that a Kirby skive, where you shave a bit off the cast, that force isn't perpendicular to the ground reaction force, so it's not giving enough push on the foot basically to put the foot up into a more neutral or a more optimum position. So they devised the MOSI. And so what you have to do is you need to take a cast of your patient. You need to mark on that cast where the patient's subtalar joint axis is, so how far medial it is. And then what the lab does is basically gets hold of the shell and just bends it up pretty much on that axis line to about 30 degrees, although it can go higher than that. So what you get, it's a bit difficult to explain, what you get is a shell which just looks like the medial side has been really aggressively tipped up. So it is really good if you've got patients who are hypermobile or patients with post-tib dysfunction, but the foot's still flexible, because a lot of those patients have really high sort of supination resistance forces. So if you're just putting a medial heel skive or a medial rear foot post on there, it's often not enough to get the foot back up into the position that you want it to. So the MOSI specifications are really aggressive prescription variable, and it does work really well on select patients. I'd be concerned, I think, with plantar fasciitis, because if they're getting the pain in the insertion point in the calcaneus, and you're putting a really aggressive force to hold the foot up in that area, I suppose I'd be a bit concerned that you'd be pushing on the bit that hurts, if that makes sense. So I think this works better for patients that got things like post-tib dysfunction than specifically plantar fasciitis. But I know that's from you, Gemma, so drop me an email and I can go through it a bit more and I can send pictures.